The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everybody, and welcome to another edition of Question Lab. It's been a couple of weeks. It's been a minute, right, since we've held this. So we're glad that you have been able to reconvene as we tackle questions related to gastrointestinal. So we're going to do a bunch of questions on GI tonight and kind of help you learn how to attack these step one questions, as well as kind of focus on key content as it relates to GI. And we'll also have a raffle at the end of the night where some lucky person is going to walk off with a subscription to RX 360 Plus. So that's what we're going to do tonight. I am going to first introduce my co-presenter tonight, Sean Nanji. Sean, would you like to introduce yourself?
Sure thing, Jeff. My name is Sean. I've been working with USMLE-Rx now for a little over 3 years. Happy to help out tonight with our question lab. Been in medical education for a little over 10 years now. Looking forward to today's webinars, and glad you all are here.
The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening and welcome to another edition of Question Lab. Tonight on this Mardi Gras edition, we're going to be tackling hematology and oncology. So put on your heme-onc hats and let's get ready to dig into some questions on blood. Tonight, I am going to be your co-host along with your old friend, Sean Nanji. Sean, would you like to introduce yourself to the crowd?
Absolutely. Thank you very much, Jeff. Happy to be here as always. My name is Sean. I've been with USMLE-Rx and Rx coach for over 3 years now, working with students like you and wonderful people like Jeff, Kate, and our coaches to help you on your academic journey. Always happy to do question labs and looking forward to this one as well. Thanks, Jeff.
If you've never been to Question Lab, or if it's been a while, let me kind of remind you how we present questions. And what we do is we follow the methodology that was established by the team at RX Coach. So, what we really want to do is we want to make sure that you're prepared for exam day, that you're prepared once you get to the point where you're ready to take step one, or really any of the key exams along your journey. And we feel like in order to do that, it makes sense for you to have a methodology that you can follow, so that you can focus and perform at your best on test day. So we're going to be, we'll talk a little bit about RX Coach later this evening, but for now, just know that the steps that we're going to be teaching you mirror the RX Coach philosophy. So we're going to open up question number one, and you're going to see something a little bit different. And it's no answer choices, and that is by design. We advise you to cover up those answer choices. And the reason we say that is because we don't want you to get distracted or dismayed by an answer choice that you're unfamiliar with. Sometimes you'll see a word or a disorder, or something that you feel like you don't know very well, or that you've forgotten, and it can knock you off your game. So what we say is, first off, you cover up those answer choices, and then second step, you read the lead-in for the question, and that is the actual question part. So in the case of this item, the lead-in is: a genetic defect in the production of which of the following is the primary underlying cause of this patient's hematuria? Okay, so you read the lead-in, and the nice thing about reading that lead-in first is that now you have a sense of what kind of information you might be looking for as you scan the vignette. Some vignettes, as you've seen before, they're packed with information, they're packed with data, they're packed with findings, and reading that lead-in gives you at least a bit of a map. At least it can help point you in the right direction. Okay, so after that, now we read the vignette. A 30-year-old woman comes to the physician because she has had dark urine every morning for the past week. Throughout the day, her urine returns to a normal yellow color. She denies burning or pain during urination. She reports feeling more fatigued than usual lately and has had abdominal pain. Temperature is 36.6, pulse is 65, respirations are 15 a minute, and blood pressure is 115/70. On physical examination, she appears pale and fatigued. A liver edge is palpated. Her urinalysis is unremarkable. Hemoglobin is 8.6, and mean corpuscular volume is 82 micrometers. Flow cytometry shows that the red blood cells are negative for CD55-59. So again, the question: a genetic defect in the production of which of the following is the primary underlying cause of this patient's hematuria? What I want you to do is go down to the question box and let us know, how many steps do you think it will take to solve this question? And as I do that, I will hand it off to Sean.
Well, thank you very much, Jeff. So we're going to go ahead and show you what we think are the important clues in the vignette and lead in. So, in the lead in, we see here, genetic defect, production, primary underlying cause. So we're probably looking at a two-step question here. We got to look at what the disease is and what the disease mechanism is to try to get to the right answer. Always important to look at demographics. We know it's a 30-year-old woman, got dark urine. That's a very important clue, happening for about a week. And then look here, it says during the day, the urine returns to a normal color. So that's going to be important. Talk about abdominal pain. She's pale and fatigued. The liver is palpated. Hemoglobin is listed there. And we have the MCV of 82. And it says that the RBCs are negative for CD55-59. So some important clues here, a couple that should jump out at you right away. So keep those in mind as we go ahead and uncover these answer choices. And when we look at the answers, we like to start at the bottom and work our way up. And the reason we do that is because we don't want you to accidentally skip an answer choice. We don't want you to accidentally, forget to read them all or see one that you think might be right and prematurely select it without going through all the choices. So we start at the bottom and work our way up. Let's do that now with answer choice E. Proteins that interact with the RBC membrane skeleton. D, mitochondrial metabolic enzyme. C, membrane-bound complement inhibitors. B, component of the hemoglobin synthesis pathway. And A, cell surface anchoring molecule. So we're going to give you all a few moments here to lock in your answers as we open up that poll and let you submit your responses.
Okay, thank you, Sean. So yes, the poll has been launched. Go ahead and let us know what you think the answer is for this one. Again, we remind you that on test day, you never want to leave a question unanswered. And on question lab nights, you definitely don't want to leave a question unanswered. It's a safe spot. You're not going to get penalized on test day. And obviously, within the confines of question lab, everything is a learning opportunity. So go ahead and fire away. And we'll go ahead and get ready to close the poll. Let's see, about almost 2/3 of you have voted. I'll give you a few more seconds. Okay, so we're going to go ahead and close the poll, and let's share these results. So based on the how long it was taking some folks, I'm guessing that this is a challenging one, and that is reflected here within the poll results. Almost a dead heat between answer choices A and C, but over 1 out of 5 also picked B. So not a clear consensus. So let's go ahead and hide these results, and we'll share the answer. And the answer is Answer choice A, cell surface anchoring molecules. So nice work. Obviously, it wasn't an overwhelming majority, but that was the leading vote getter tonight. So we're going to count that one as a win. But we understand quite a few of you did not get that one right. So that's okay. Sean is going to help you understand what went wrong. Sean?
Well, thank you, Jeff. Yes, definitely a challenging question. We've got a lot of challenging questions in USMLE-Rx. If you haven't, visited our Q bank lately, go take a look. We have a lot of updated questions, and as you can see here, we've got some very challenging ones itself. So let's go ahead and move on to the next slide here, and we'll go over the correct and incorrect answers like we always do. So the correct answer is cell surface anchoring molecule. In order to get that right, we first need to figure out what the disease process is that's occurring here. And so this patient's most likely diagnosis is likely PNH, which is paroxysmal nocturnal hemoglobinuria. And the key takeaway point from that vignette that'll help you get this question right and get to that diagnosis is the fact that this patient has fatigue, abdominal pain, but the biggest one is a dark urine that resolves as the day progresses. Okay, so that's what we need to take away from it. Okay, so PNH presents with fatigue, abdominal pain, and dark colored urine that classically resolves during the day. And it's a disease that's caused by an abnormality in the PIGA gene. And what that does is, as a result of that gene, which is on the X chromosome, it normally helps produce those GPI anchors. And so many proteins use those anchors to attach to the extracellular surface of cells. So when that gene is mutated, it results in impaired synthesis of those GPI anchors. And as a result of that, you're not going to have them. And so what happens is these normally act to inhibit complement and prevent the host cells from being lysed or broken up by non-specific activation of the complement pathway. Now, because the RBCs in PNH are missing these anchors, they do not have CD55 and CD59 cells, CD59 on the cell surface. So those two clues about the dark urine and the missing CD5 and CD59 should take you right to PNH. So hematuria is most likely noticeable, is most noticeable in the morning, because what happens is morning urine tends to be more concentrated, and that's because when you're sleeping, you're not taking in that fluid, and so that urine is going to be more concentrated. And so as that resolves during the day, you see that clear up a little bit. So that's why that's the correct answer. You see a nice little chart here from First Aid, which talks about PNH, and as you can see here on the right side there under labs, CD59, 55, and 59 are negative. So the correct answer here is going to be what you selected, which is cell surface anchoring molecules. Okay, so once again, definitely a challenging question. Let's take a look and see why the other answers are incorrect. Okay, if you selected a defect in the component of the hemoglobin synthesis pathway, that's usually happen when you have alpha or beta thalassemia, which will lead to microcytic type of things. This is actually normocytic anemia, not microcytic. So keep that in mind. And anytime you have alpha or beta thalassemia, not only will it be microcytic, it'll also be hypochromic anemias, and you'll also have bone marrow hyperplasia. If you have proteins that interact with the RBC membrane skeleton, that's usually going to be in hereditary spherocytosis. And the patient will likely have some of the similar presenting symptoms like fatigue, but they're also going to have jaundice, shortness of breath, and splenomegaly. We didn't see that here. If it was a mitochondrial metabolic enzyme, that would be a maternal inheritance pattern, and some of you might have gotten thrown off with that one. It does have some similar things. You're always going to see that fatigue, but you're also going to have, if it's a mitochondrial metabolic enzyme, there's some GI disorders. You're going to have cardiac disease, liver disease, respiratory complications, etc. You're not going to have this urine that resolves and the lack of CD55 and 59. So definitely a challenging question. If you need help with this one, take a look at that chart we showed you in First Aid. And as always, we'll share this question ID with you so you can take a look on your own time. But great job, everyone. And let's move on to the next one.
Excellent. Yep. Thanks, Sean. Yeah, this is, a tough one. Hopefully shook out some of the cobwebs and got you guys focused on our topic tonight. So let's open up question number 2. Again, we've got those answer choices. We've got those answer choices covered, and actually we've got part of the question covered too. So let me see if I can stop showing for just a second. Let's see if I can get this adjusted. Okay. These, these histo slides always can cause trouble. Okay, let's go ahead and start it back up. Okay, great. So let's show the PowerPoint. Now, got the answer choices covered up, and we're going to start with that lead in. Which of the following complications is most associated with this patient's most likely disease? Okay, so you kind of understand what you're looking for. You've already seen the you've already seen the slide here, so let's go ahead and read the vignette. A 64-year-old male comes to his physician because of a 3-month history of lethargy and cough with brownish sputum. He has been treated twice in the past 3 months for community-acquired pneumonia. Temperature is 39.1. Physical examination is significant for right-sided pulmonary crackles, non-tender cervical and axillary lymphadenopathy, and hepatosplenomegaly. Laboratory studies show the following: leukocyte count 40,000, neutrophils 20%, lymphocytes 77%, eosinophils 1%, monocytes 1.5%, basophils 0.5%, hemoglobin 8.2, platelet count 190,000. An image of his blood smear is shown. So once again, the question: which of the following complications is most associated with this patient's most likely disease? Key in on that and let us know down in the question box how many steps you think it's going to take to answer this one as I pass it off to Sean.
Well, thank you very much, Jeff. Once again, we're going to go ahead and show you what we believe are the important clues in the lead in and the vignette here. So as you can see here, we're looking for a complication that's associated with this most likely diagnosis of this patient, right? So we see that the patient, 64 years old, got a 3-month history of lethargy, cough, brown sputum. He's been treated twice in the past 3 months for community-acquired pneumonia. As you can see, he's got a fever of 102.4, right-sided pulmonary crackles, non-tender cervical and axillary lymphadenopathy, and hepatosplenomegaly. Look at leukocyte count, 40,000. Neutrophils 20%, lymphocytes 77%, eosinophils 1%, monocytes 1.5, basophils 0.5, hemoglobin 8.2, and platelets at 190. So let's go ahead and show you a picture of that blood smear, and a large one, as we move on to the next slide so you can take a closer look. So you can see the blood smear there. All right, let's go ahead and move on now and take a look at the answer choices. Once again, we're going to start at E and work our way up. E, progression to blast crisis. D, lytic bone lesions. D, disseminated intravascular coagulation, or DIC. B, autoinfarction of the spleen. And A, autoimmune hemolytic anemia. So we'll give all of you a few seconds here to lock in your answers as we open up that poll.
Okay. The poll has been launched. Go ahead and select the complication you think is most associated with this patient's most likely disease. Love these questions that, really kind of force you to, think through your options figure out what it is that that this patient is probably dealing with. It's really this kind of level of reasoning that makes it challenging. It makes it challenging on test day because you really have to be able to kind of think through the options that are in front of you and and quickly think, hey, what is the likelihood here for this one? So let's see. We've got almost 2/3 of you have voted. Interesting. We've got another another very even array of percentages here. So let's go ahead and we're going to close the poll and share the results. So look at that. I think this is, again, kind of an indication. Tough question, and not exactly sure which of these complications it would be. So again, progression of blast crisis and autoimmune hemolytic anemia, both leading vote getters, disseminated intravascular coagulation right on its heels, but lytic bone lesions is also there. So so no clear favorite. So let's hide the results and get ready to share the correct answer. And the correct answer is answer choice A, autoimmune hemolytic anemia. This was number 2 in terms of votes. But as we noted, it was pretty even split amongst the top 4 vote getters. So we know this was another challenging one. So Sean, let us know how we would break this one down.
Sounds great. Thanks, Jeff. So, first and foremost, we've got to figure out what the diagnosis is, right? And if you're looking at the presentation of lethargy, frequent infections, lymphadenopathy, hepatosplenomegaly, and a high white blood cell count, and as you saw in the smear, in the blood smear there, you saw a lot of these small, like these lymphocytes and smudge cells, right? And those smudge cells are going to be a classic clue, along with the symptoms, that this patient has CLL, or chronic lymphocytic leukemia. Okay, and that's a relatively common lymphoproliferative disorder of B cells, and it usually happens in patients above 60 years old. Now, normally at the beginning, it's asymptomatic, but as these malignant lymphocytes start to infiltrate the bone marrow and these peripheral organs, what happens is these patients develop bone marrow failure, lymphadenopathy, and hepatosplenomegaly. And you'll see that, in these patients, autoimmune hemolytic anemia is a known complication of CLL. And that happens because you have these autoantibodies that are produced by either the malignant lymphocytes or the remaining normal lymphoid cells, right? So some other complications of CLL, just so we could, learn about it all together, you could see skin lesions and pharyngeal disease. You can also have a hypogammaglobulinuria due to a defect in these non-neoplastic beta cells, which will then lead to an increased infection risk. So, in summary here, we've got to think about CLL presenting with lymphadenopathy and splenomegaly due to that extramedullary hematopoiesis, frequent infection, and autoimmune hemolytic anemia. And you'll see these small, mature appearing lymphocytes and smudge cells, and patients with CLL will have an increased risk of autoimmune hemolytic anemia, as well as infection due to hypogammaglobulinuria. Okay, why are the other answers incorrect? Well, let's take a look here at the other ones, just for good measure. And when you're doing questions on your own, it's important to look at the and if you go to USMLE-Rx, you'll actually see the explanation broken down by steps. You'll see step 1, step 2. And it's important to follow along so that, you want to make sure you got it right for the right reason. But if you missed it, you want to see where are you missing it? Which step did you mess up on, right? And also always look at the incorrect answers and the explanations so you can learn from that question, because there's many different ways a test writer can ask you a question, right? And people always ask, which question bank is more similar to the USMLE? And the answer is there really isn't one, right? Because there's different test writers that write these questions. So as long as you know the material and how to think through it, it doesn't matter who writes that question, you should be able to get it right. So let's take a look at these incorrect answers here. So progression of blast crisis, you know, that's going to be CML, and you can see that progression of blast crisis then. And what you'll see is when you do that peripheral smear, you're going to see a predominance of neutrophils, and we did not see that here. Lytic bone lesions, and you'll see these, and I can tell you by experience because I have a couple of them. They're pretty painful, and they're generally associated with multiple myeloma. Okay, and people who have multiple myeloma will generally present with renal insufficiency, and you'll see a monoclonal M spike on electrophoresis and increased serum plasma cells. So we didn't see that here, right? With DIC, you're going to see that with acute promyelocytic leukemia, and you'll see what they call AUR rods, AUER rods, and we didn't see those rods in this smear. So if you selected that answer, you know, you might want to take a look at those smears. I know it gets confusing between all the different kinds of leukemias and things that are out there, but oftentimes, you know, there's that one characteristic trait on a smear that can help you get to the right answer. And so one thing that a lot of students do is they'll just take a list or make a list or a chart with those smears and write down the keyword in that diagnosis. And if you do that, visually putting them next to each other on one page, it may help you do that. And First Aid does that very nicely for you. So take a look at that if you need to. So that's why the other answer choices are incorrect here. Autoinfarction of the spleen, that's going to happen when patients have sickle cell anemia, not necessarily what we're seeing here. So once again, the answer is going to be autoimmune hemolytic anemia due to this patient having CLL. So great job, everyone. Let's move on to the next.
Excellent, thanks, Sean. Yeah, think about the crushed little lymphocytes, CLL. So when you see those smudge cells, let that be a trigger for you. And again, we've got in USMLE-Rx, obviously, when you're looking at any of the explanations for the QMAX questions, we always have the pages from First Aid available for you. So again, a great tool for learning and review. Sean, let me give you a minute here. Just talk a little bit about RX Coach.
Yeah, you know, one of the things that, you know, we see a lot with students is, you know, they'll come to us and say, you know, I've been studying for this long, but my scores aren't going up, right? Or my friend said to do this, and I tried doing what they said, and that didn't work for me. Or, you know, I read online that if I do this question bank twice, I'll be good. So a couple of things here. Doing the same question bank twice has actually scientifically been shown to not help you, okay? So that's not us telling you, that's just science, right? And what worked for your friend, as well-intentioned as they are to try to give you great advice, just remember that everybody's different, right? Like you and your peers, you have different learning styles, different strengths, different weaknesses, right? You learn at different speeds, and you have different ways of learning that are better for you as opposed to somebody else. And so what happens oftentimes is these students are kind of spinning their wheels trying to figure out what the most effective and efficient way to study is for students, because let's face it, as medical students, you know, there's not a lot of time that you have to go waste and try things, right? And then it becomes, okay, you know, even if you found a way that works for you, how do you maximize that to make sure that you're successful on test day, right? And we had a lot of students who really took step one for granted, right? And if you look at the newest USMLE data, we had a lot of students that failed this year compared to any other year. And so don't take for granted the fact that this test is pass-fail, because you want to do well on it to set yourself up for success in rotations and to hopefully eventually become a good doctor. That should be your goal. But also to have a strong foundation for step two, so that you can have a strong 3-digit score on step two and move on. So what we do at USMLE-Rx and RX Coach is we take a personalized approach, right? We'll give you an assessment. We'll look at that assessment. We'll have you fill out a sheet about your strengths and weaknesses, your learning style. And then based on your assessment and your answers, we will figure out a effective and personalized study plan for you that will be different compared to everybody else, right? And then we'll say, okay, you know, this week we're going to focus on this subject, and these are the tasks that you're going to do for this topic, and these are how many questions you're going to do each day for this topic. Then when you're done, you come back and we schedule a tutoring session. We go over that subject together. We do questions together. And as you're doing questions, when you're starting to think out loud about why the answer choice is right or wrong, we can start to see what your thought pattern is like. We can identify those strengths and weaknesses. And at the same time that we're bridging those knowledge gaps and building that knowledge foundation, we can start to work with you on your test taking skills. And that's why we've had so much success with RX Coach, so much so that we actually had to stop accepting new students for a while. And we still take students in very limited quantities to make sure that all of our tutors have enough time for their students. So, we have some availability now. If you're interested in working with a coach, I encourage you to visit us online at rx-coach.com or rx-coach.com. We've helped people who graduated 15, 16, 17 years ago who've come back and done well on their exam. So if we can help them, we certainly can help you. It just depends on whether you want us to get involved or not, right? And oftentimes, we have a lot of IMGs that come to these question labs that have been out of that academic environment for a while. And it's hard then to kind of get that mentorship that you need and know where to start to get to where you want to be. So, if we can help you, we're always here to give you that individualized attention that you deserve and need. You can schedule a free consultation at rx-coach.com to set up that free consult, talk to us about RX Coach and how it can benefit you. So, encourage you all to take a look.
Excellent. Thanks, Sean. So yeah, definitely we've got the link there for you so you can set up that free consult and learn more about our program. So we're going to head into question number 3. Again, we do have a raffle at the end of the evening, so stick around. And what we're going to do, as is our usual MO, we've got these answer choices covered up for you, and we're going to start off by reading the lead-in. Which of the following is most likely to be associated with this patient's likely condition? Okay, there you go. You got two more likelies here within that lead-in. So, understanding a little bit about what you're going to be looking for as well. You've got another smear there to look at. Let's go ahead and tackle the vignette. A 63-year-old woman comes to the office because of worsening fatigue for the past 2 weeks. She's also started noticing bruising on her skin and lips. The patient appears pale on physical examination. No enlarged lymph nodes are present, nor is there hepatosplenomegaly. Non-blanchable petechiae are present on the lower limbs. A complete blood count reveals the following: hemoglobin 8, platelets 67,000, leukocytes 3,000, myoblasts 30%, promyelocytes 10%, myelocytes less than 5%, metamyelocytes also less than 5%, mature myelocytes 50%. The patient's peripheral blood smear is shown. So again, which of the following is most likely to be associated with this patient's likely condition? Think about that. Let us know in the question box how many steps you think it's going to take to solve this one. And I'm going to turn it over to Sean.
Well, thank you very much, Jeff. So as you can see here, we're going to go ahead and show you what we believe are the important clues in the vignette and lead-in. And obviously, we're looking for the most likely thing to be associated with this patient's condition. So similar to what we did before. And if you listen to my explanation, then I gave you a little bit of a clue about what was coming and certain things you see in blood smears. And if you look at that blood smear, you're going to see what I talked about earlier. You got a 63-year-old woman, worsening fatigue for past 2 weeks. She's got bruising on her skin and lips. She's pale, no enlarged lymph nodes, no hepatosplenomegaly, got non-blanchable petechiae on the lower limbs. And look at the values there: 8 for hemoglobin, platelets at 67,000, leukocytes at 3,000, myeloblasts 30%, promyelocytes 10%, myelocytes at less than 5, metamyelocytes less than 5, mature myelocytes at 50. So let's go ahead and take a look at that blood smear. And what do you see there? Hopefully we're able to take a look. Let's go ahead now and uncover those answer choices. Answer choice E: microangiopathic hemolytic anemia, increased leukocyte alkaline phosphatase, greater than 20% lymphocytes in bone marrow, decreased plasma von Willebrand factor activity, and A, blastic bone lesions. So we'll give all of you a few seconds now as you open up that poll to lock in your answers.
Okay, everybody, the poll has been launched. let us know out of all of these things, what do you think is most likely to be associated with this patient's likely condition? What do you think that this patient has, right? And knowing that, what are you most likely going to see? I also want to apologize for the poor pronunciation of petechiae. That one trips me up. Let's see, we've got about half of you have voted, so I'm going to give you another 10 seconds, and I'm going to close that poll. So, boy, I tell you what, I'm looking at these at the results as they come in, and we've still got pretty much a split decision here. We've got 4 answer choices that are ranking in the double digits. Oh, actually, now all 5 of them are double digits. Let's go ahead and close that poll, and we'll share the results. So 28% of you thought that you would see greater than 20% lymphoblasts in bone marrow, and about a quarter of you went with microangiopathic hemolytic anemia. But increased leukocyte alkaline phosphatase and blastic bone lesions right on their heels. So again, no overwhelming favorite here amongst the crowd. So I'm going to go ahead and hide the results, and we're going to reveal the answer, and the answer is answer choice E, microangiopathic hemolytic anemia. So interesting. Again, the second place vote getter takes the prize. So well done, everybody who got that one right. If you didn't, that's okay. Sean's going to help dissect it for you. Sean?
Well, thank you very much. Once again, another challenging question here. As you can see, we're doing a lot of these, CLL, AML, and these types of questions because that's something that students usually have issues with, right? So, first thing to figure out here is what did we see in that blood smear, and what we saw in that blood smear were our rods, right? And I mentioned that when we talked about question 2. So this patient likely has what we call APML, which is a subtype of AML. So AML is acute myelogenous leukemia, AML, and APML, which is a subtype of that, is acute promyelocytic leukemia, okay? So you're gonna see those our rods with these myelogenous cells. You're gonna see this low hemoglobin, progressive fatigue, and pallor, and you're gonna see a low platelet count and petechiae. Now, APML is a hematologic malignancy, and it's seen also in patients that are older than 60, all right? And so what'll happen is you'll eventually have bone marrow failure. And APML is associated with a translocation. Do you guys know what that translocation is? It's the 15-17 translocation, which causes failure of these immature myeloid precursors or myeloblasts to differentiate into mature granulocytes such as neutrophils and eosinophils, and that's why you're going to see more than 20% myeloblasts in a patient with AML. So you see here, you have the our rods in the smear there, and so that's going to be another big clue here. So what happens is these microthrombi will obstruct the vessel and shear these erythrocytes as they pass through, and we call that phenomenon microangiopathic hemolytic anemia, or MAHA. So this is a immune hemolysis, and that leads to RBC fragments, schistocytes, and other things. So the answer here is going to be microangiopathic hemolytic anemia due to this patient having APML. So keep that in mind here. I know it's another challenging question. You can see here another little a chart here that you may find helpful as we talk about these myeloid neoplasms. Let's take a look at the other answer choices here. D, finding more than 20% lymphoblasts. That's going to happen in acute lymphoblastic leukemia, or ALL, which is a very common childhood cancer. This patient was over 60 years old, and that's why these demographics are important. Von Willebrand disease here, let's go back to D here. Leukocyte alkaline phosphatase, that's an enzyme that's in mature white blood cells, and it'll increase during stress, infection, polycythemia vera, and primary myelofibrosis, and it would be decreased in this disease. It'll be decreased in it, but what we're looking for here is a little bit different, as we are not going to see an increase in leukocyte alkaline phosphatase. We're going to see the opposite. Okay, so that's why that answer is wrong. Looking at greater than 20%, we already talked about that one. Decreased von Willebrand. So von Willebrand disease, that's a mixed coagulation disorder, and we characterize that by either functional, qualitative, or quantitative plasma von Willebrand factor. As you may remember, that is an essential adhesive protein in the platelet vessel wall, and so patients that have that may exhibit, mucocutaneous bleeding and easy bruising. We didn't have that with this patient. Blastic bone lesions. So when we see these blastic bone lesions on X-ray, right, we're going to see that in certain cancers that will metastasize to the bone, and the most common ones there are usually going to be prostate cancer and breast cancer. Okay, so the big trick here to getting this one right is recognizing once again those hour rods, realizing that this patient does in fact have APML, which is a subtype of AML. All right, so once again, another challenging question. Let's move on, try to finish strong with our last question here.
Okay, yes, thanks, Sean. Again, you've gotten some good questions tonight. Hopefully, you're learning something, and maybe we can have our best question of the night here to close it out. Again, we'll have the raffle after this, so let's open this one up. And again, we're going to start with the lead-in. This patient's excessive bleeding is most likely to be associated with which set of laboratory results? Okay, and then you see down there in the lower right-hand corner what those lab results are. So with that information, now you kind of understand, okay, there's going to be excessive bleeding, right? And you're looking for how it would connect to some of the key lab results. Okay, with that, let's read the lead-in, or the vignette. Excuse me. A 63-year-old male comes to the emergency department 4 hours after a fall with ongoing bleeding inside his mouth that started when he fell. He has chronic kidney disease due to type 2 diabetes. He has no family history of bleeding disorders. Temperature is 37.5. Pulse is 103 and regular. Respirations are 16 per minute, and blood pressure is 150/90. Physical examination shows bleeding from his cheeks and gums and ecchymoses over his extremities. Laboratory studies are as follows. Leukocyte count, 7.4. Hematocrit, 41%. Mean corpuscular volume, 91. Mean corpuscular hemoglobin concentration, 35.3. Red blood cell distribution width, 11.3. Blood urea nitrogen, 90. Creatinine, 7.3. Glucose, 100. Total bilirubin, 0.8. Bleeding time, increased. So again, this patient's excessive bleeding is most likely to be associated with which set of lab results. And with that, I will pass it to Sean.
All right, so I know I said let's finish strong, but this is going to be our most challenging question of the night, okay? So let's take a good look at these important clues. That excessive bleeding is most likely associated with which set of results? So once again, 63-year-old male, 4 hours after a fall with ongoing bleeding inside his mouth. Got chronic kidney disease due to type 2 diabetes, no family history of bleeding disorder. So that should help out a lot here. Normal temperature, look at that pulse of 103. Bleeding from his cheeks and gums and ecchymosis over his extremities. Look at those lab values. Leukocyte 7.4, 41 MCV. Hematocrit 41, MCV of 91. Mean corpuscular hemoglobin concentration of 35.3, RBC distribution width of 11.3, nitrogen 90, creatinine 7.3, glucose 100, total bilirubin 0.8. And the bleeding time has increased. So this patient's excessive bleeding is due to which set of lab results? So as you can see here, our answer choices are going to be A3. So now that you've read everything, we'll give you a moment here to take a look at that chart as we uncover the answer choices, which, as you can predict, will be A3, looking at that chart. So let's go ahead and move on to the next slide here. So a little enlargement of your answer choices. So take a look at that. We'll give you a few moments here to lock in your answers before we open up that poll. Now, with these charts, the most important thing to do is look at the column that you're most comfortable with. If it's prothrombin time or activated partial thromboplastin time or platelet count, look at whichever one you're most comfortable with, right? And look at what that should be, and then mark out the other ones. Then go to your second most strong suit, right? And then knock out the ones that don't fit in. And if you do that, you'll, you're going to increase your chances of getting that question right? And so that's just a test taking strategy that you can use anytime you see a chart, right? And you're going to see those often, but if you do that, you can likely save time and eliminate a lot of the answers and get to that correct one, okay? So with that being said, hopefully you'll use that trick. We're going to go ahead and open up that poll, let you lock in your answers.
Okay, that poll's open, so hopefully you already know which one you were going to select, so just go ahead and let her rip. Yes, we saved the toughest one for last. Not unusual, but again, that's a good example of the type of question that you're going to see on the step 1 exam. Long vignette, lots of data to figure out regarding the patient, and multi-step setup. Okay, so almost 70% of you have voted, so I'm going to go ahead and close the poll, and we'll share the results. And as we've seen all night, we've been we've had a pretty even distribution of answers for most of the questions, and we've got a dead heat here between answer choices A and B for this one. So let's go ahead and hide the results, and we will share the answer. And the answer is answer choice C. So the third place vote getter is the correct answer. So let's dig into this one, Sean. What did we get? What confused us here?
Well, this is a challenging question. You got to know your physio to get this one right. And renal physio tends to be a tough one, and you combine that with the hematology questions. So you set up two challenging subjects here you got to put together to get right. And that's what physiology does, right? It really makes you think about things. And so, if you're out there thinking, I should have gotten that, or I almost got it, or you weren't able to think through it, don't worry. I'm going to explain it to you now. But, we're always here at RX Coach to help you refine that process and help you kind of pinpoint why you're missing some of those steps that you might be missing. So, we know that this patient has a pretty high BUN and creatinine, right? We already know they've got kidney disease. So this is pointing us to end stage renal disease, all right? And as a result, now we know that he's got prolonged mucosal bleeding, multiple bruises, and that suggests uremic platelet dysfunction, which happens in end stage renal disease. And so what happens is these uremic toxins will accumulate and interfere with the platelet endothelium and platelet aggregation and adhesion. And so these abnormalities interfere with the formation of the platelet plug, which is primary hemostasis, which is a type of qualitative platelet disorder, which is decreased platelet function, okay? So what happens here is in this qualitative platelet disorder, the coagulation cascade, the clotting factors are normal, okay, as is number of platelets. So for what you're gonna see is you're gonna see a normal prothrombin time, a normal partial thromboplast time and platelet count. The bleeding time, however, will still be increased, okay, and that bleeding, like I said, you're gonna see that in end-stage renal disease. And once again, it's important to realize that the reason for that is because you have a deficiency and a problem in primary hemostasis. You're going to have normal things otherwise. You're going to have all these things are going to be normal. And the reason is, well, not the reason really, but one of the things that you can look out for, right, when you see this, and the kind of the clue here is to realize it's uremic platelet dysfunction. And the way you're going to get that right is you're going to look for a couple things. First thing, you're going to see if they have these elevated BUN creatinine levels, right? You're going to see if they mentioned them having kidney disease already, or mentioning symptoms, okay, or presenting signs and symptoms of somebody who has kidney disease. And if you see that, you want to start thinking end-stage renal disease. And what happens in end-stage renal disease? Well, what's going to happen then is you're going to have an accumulation of these uremic toxins that will interfere with platelet endothelium interaction and platelet adhesion and aggregation, okay? So why are the other choices incorrect? E, so you'll have an increased APTT and normal PT with a decreased platelet count. Well, that's not typical of acute bleeding disorders, but you could see that in chronic DIC. And you would see that when you have recurrent thrombosis in somebody who has a malignancy generally, and we don't see that here. D, that'll generally be something that presents in childhood. We're looking at, hemophilia A or B, and it'll affect other family members. They told us in this one that there was no family history of bleeding. And so that's why D is going to be incorrect. B, once again, is talking about something like DIC, which will lead to a deficiency of clotting factors. We don't have a deficiency of clotting factors here. And A, decreased platelets in the setting of normal PT and PTT, that'll be seen in, immune thrombocytopenia, maybe even thrombocytic thrombocytopenia, purpura, or in hemolytic uremic syndrome. And so if you started going down that hemolytic uremic syndrome, you were thinking about the uremic buildup, remember that HUS or hemolytic uremic syndrome usually happens after somebody eats meat. And the way I remember HUS is HUS for hemolytic uremic syndrome, or for hamburger, undercooked, sick. Okay, so that's my mnemonic for that one. So, a lot of tough questions today. We are going to show you the question IDs so you can take a look at these on your own time and really kind of understand the physio and why these answer choices are correct and incorrect. But the reason why we put these questions together, right, is you're going to see these on your test, right? And even though we alluded and gave you some hints, and we got a question that was about those hints right afterwards, we saw students struggling with it, right? And this is a topic that does that can cause students to sometimes, second guess themselves or realize that they may need a little bit more help. So that's what we're here for. So here are the QIDs. We'll leave these up for a few seconds as you can, so it gives you time to take note or take a screenshot, and I'll hand it back over to you, Jeff.
Yeah, excellent. Thank you, Sean. And this is a great way for you to review any of these items that you may have missed, or items that maybe you got right, but you're not exactly sure that you feel fully confident on these. And the nice thing about it, within the USMLE-Rx system is that, for any of these items, you'll also see the associated pages from first aid, the associated flash facts, express videos, and RX bricks. So lots of different ways in which you can supplement and remediate when needed.